Hello. So welcome back. This room is going to be Lobular 102, where we're going to do a deeper dive into metastasis and clinical. We're hoping to leave a lot of time for your Q&A here, and you're going to have, again, postcards on the table, and we'll have someone who is picking them up and bringing them, and I will try my best to sort them out, and we'll try to get as many questions answered as we can in this session. Once again, I want to remind everyone that the conference is not designed to respond to individual cases. The appropriate use of information from this conference would really be to go back, take the information you learn, and make informed questions with your doctor and your medical team. And also remember that this is information that is based on the most current scientific evidence. But all of us are different people, different bodies, different tumors, and you shouldn't let what you hear in this conference and in this session guide your treatment decisions alone. So again, I want to introduce our speakers who are here tonight. We have Dr. Steffi Oesterreich she's a professor at the McGee Women's Research Institute at the University of Pittsburgh. She is a Komen Scholar. Her primary area of interest is endocrine resistance in breast cancer with a focus on lobular breast cancer. And she was co-chair of the first international symposium on ILC in Pittsburgh, which was very exciting to have an entire symposium devoted specifically to lobular breast cancer. And she is also working she has a grant from the Metastatic Breast Cancer Network to study some of the genetic and epigenetic changes with unique metastatic sites of ILC and GI in the ovary, which we're all very excited to learn more about that. And then we also will be following immediately with Dr. Hannah Linden. She is a clinician at the Seattle Cancer Care Alliance and a professor at the University of Washington School of Medicine, a full member of Fred Hutchinson Cancer Research Center. She has extensive experience treating lobular metastasis and lobular breast disease. And she is also currently leading a Seattle arm of an early stage trial to understand endocrine response in women with ILC, and this is one of the few ILC-specific clinical trials that's going on right now. So, thank you.
Hello, everybody. I'm back. First of all, I would really like to thank Joyce and Lee and everybody else again organizing this, because I think it turned out, the morning session was great. So thank you very, very much. I think when we organized this, we said we don't know if the audience is 100% the same in the morning as the afternoon. So I have the first two slides are the same as in the morning. I guess you could now describe those slides, right? Hopefully. So very briefly, I go through those. The same slides as this morning. So again, ILC represents only 10 to 15% of all breast cancers. But because breast cancer in general is so frequent, this is more than 30,000 women a year. And it ranks as the sixth most frequent common cancer in women. And if you take numbers on its own, it would be more frequent as compared to brain tumors or multiple myeloma as a whole. It does remain understudied. And very briefly again, they grow on these sheets because the tumors lose equilibrium, therefore the cells don't attach each other. And what I tried to explain this morning, you can see this here, that the tumor cells are really, instead of being surrounded by another tumor cells, they're surrounded by other stuff. Could be other cells, could be just stuff the cells secrete, but it's very, very different to ductal tumors. And again, they lose equilibrium, mostly ER/PR positive. They don't grow very fast. They grow on these long sheets, and there are multiple histologies, which I talked about earlier in the morning. On the next two slides, I'm going to show you results from 4 studies, and I specifically show 4 studies because the data is still somewhat, I don't want to say controversial, but I think it is important to have sufficient number of patients to really convince ourselves that that is true and that we can actually say it's true that there are more late recurrences. So I'm going to show you 4 studies. So this is the largest study. It was published in a great journal of Clinical Oncology. It's almost 10 years ago. And you can see the numbers of patients with IDC or ILC here. And this is what we call a Kaplan-Meier survival curve. So this is time after random assignments in year. This is after random assignment because this is from various clinical trials. And this is disease-free survival. And you can see, and the yellow line is patients with invasive lobular cancer, and the blue is ductal cancer. And you can see that in the beginning, the patients with invasive lobular cancer do a little bit better. There are fewer recurrences. But then there seems to be an inflection point around 5 or 6 years. And suddenly, there are more recurrences for patients with ILC. This is a larger study. But there are 3 other studies which were published over the last 2 years which all support the same idea. There are more late recurrences. This one here, specifically comparing grade 2 patients. And the red line is lobular. The blue line is ductal. And you can see, again, that there are more recurrences. Somewhat specifically, the curves separate at 4 or 5 years in patients with lobular cancer. Again, saying there are more late recurrences. It's a totally different study. 2 other studies. One, this is actually, here, Adachi et al. It just was published last year. The numbers are smaller, but similar findings. Again, approximately at 6 years, these curves separate, and the recurrences are more frequent in patients with ILC. And finally, one last study is a very large European data set. You can see this result is not what we call significance when the p-value is below 0.05, but still you can clearly see that the curves, the red curves and the blue curves separate. So again, at one point in the first 3 or 4 or 5 years, recurrence rates are very similar, but then after 5 years and later, there are more late recurrences in patients with ILC. So clearly, I think it is absolutely important for us to understand what causes those cells to recur as metastatic disease many years after diagnosis of the primary disease. Just a few facts we know now, although the studies are still relatively small. We are still collecting data, but there are, in general, decreased metastatic events to visceral sites, like liver and lung. There are increased metastasis to the bone. That, if you correct that for estrogen receptor contents, then that difference is not significant. We just see more to the bone because that's where ER-positive disease go to. And what we already touched on this morning, there are clearly more unique sites of metastasis, specifically in the GI tract, in the peritoneum, and the ovary. There's one study here I like to show. This is pretty old. You can see this was published in 1984. But I'm showing this because there are very, very few studies published which look at unique sites of metastasis in patients with ILC. This is a comparison of the metastatic pattern of infiltrating lobular carcinoma and infiltrating ductal carcinoma of the breast. And they show that lung mets are more common in IDC, bone mets are more likely positive in ILC, metastasis, carcinomatosis, meningitis is almost exclusively with ILC, and then peritoneal, retroperitoneal metastasis in the stomach and in the uterus was more frequent in ILC. And they, at the end, they state something. The most striking was widespread involvement of peritoneal surfaces and retroperitoneum, diffuse multiple tiny nodules, 1 to 2 millimeters diameter, which then became very confluent. And they saw a very highly significant difference between patients with IDC and ILC. So this is something our lab decided to study. And I mentioned this earlier. I'm very grateful to BCRF, the Metastatic Breast Cancer Network, and Komen to fund these studies. Specifically, this is funded by MBCN. So we started to look in our database at the University of Pittsburgh Cancer Institute, where we have a very large registry of metastatic breast cancer. So somebody went in to fully abstract medical records and outcome and information on metastatic disease for patients seen between 1998 and 2012. And we have 761 patients with ILC and IDC, where we have complete information about primary, or the first site of metastasis, the second site, the third site, etc. And we looked specifically at patients with ILC and IDC and compared recurrence. And the first thing we observed, again confirming that patients with ILC recurred with distant metastatic disease later than those with IDC. And the second, that we saw significant differences. And a little bit it depended actually on the first site and the course of disease. So this is shown here. So basically, we observed, and that confirms prior study, that there were less metastasis in the liver and the lung, but there were more metastatic lesions in the GI tract and in the bone. If we specifically also involve at metastatic sites, which second and third and later throughout the disease, then we see this for the ovary as well. So we have now tried to collect the tissue, and we discussed earlier that's not an easy undertaking. I think there aren't many metastatic tissue there, but we have collected now quite a few, and we have done two things. We have done just staining for E-cadherin. The question being, is the overall pathology the same? Is E-cadherin still gone? And does the tumor still grow in these weird strings and spider webs, just like in the primary? And so far, the answer is yes. And without going through this, I can just tell you that the staining for lobular cancer, the way we do this is that basically you get a pinkish color when E-cadherin is lost. And you can see this here in two examples. So these are metastases to the ovary. Whereas in ductal cancer, it still looks like a ductal cancer if you look in the ovary. So the primary and the metastasis look very, very similar. And the second thing we have done, we have now looked at the expression of genes in these ovarian mets. So we have now sequenced 47 of these ovarian mets. And you can very nicely separate, without going through this, this is just pattern of expression of genes. We can clearly separate primary disease and metastatic disease. And the bioinformatics in the group, they now look at specific genes and pathways which are higher expressed in the ovarian mets with a goal for us to target those. Obviously, the goal in a few years from now is to not even have it go to the ovary, but block those pathways from early on. What we are doing at this very moment is that the pathways and genes, which we found to be very highly expressed in the ovary, we then go back to the cells. So we have cells growing in plastic dishes in the lab, and we have representative cells of ductal cancer, of lobular cancers. You can see the brown staining, they express ER, and they behave like a lobular cancer in our culture dishes. And we now take these genes and either put more of these genes on, or we block them genetically, or if there are like drugs out there with drugs, and see whether we can block metastasis to the ovary. And this is done. Again, I just described this. We put these in tissue and culture dishes. We put them in mice and look at metastasis to the ovary. So this is ongoing. So to summarize, loss of E-cadherin is a hallmark of ILC. Loss of E-cadherin is maintained in the metastasis. A subset of these ILCs recur, and that can happen really late after diagnosis of the primary disease, many years after the original diagnosis. ILC metastasis, there's less involvement of visceral organs, and clearly there are unique sites like GI, peritoneum, and ovary. And the research emphasis and needs is clearly the access to metastatic tissue. This is very important because only that really allows us to understand and to identify these drivers, why these tumors go there. We need more models, although we increasingly have more models still. Again, given it's only 10% of all breast cancers, the focus was not on developing models for lobular disease. But we are working on this. Many other groups are working on this. This is absolutely critical for us to make progress. And we haven't talked about this, but also to think about studies of longitudinal liquid biopsies in patients with ILC is absolutely critical. I think in contrast to patients with IDC, we know exactly one mutation which you can follow over time, right? When you do this in IDC, you never know what the driver mutation is. In the lobular tumor, we know in more than 90% ECATERIN is mutated. You can find that specific mutation, and you could, in theory, follow this over time and look at liquid biopsies for this one specific mutation. So that's clearly something we should do. One sec. I would like to thank, again, all the people in my lab who do all the work, collaborating very closely with Dr. Lee's lab next door, many, many collaborators, patients who donated tissue, the funding agency. Thank you very much for your attention.
Okay, so moving along with some repetition, but I think hopefully some new ideas. So one of the things that I think is important to realize is all lobular tumors are not exactly the same. There's this classic low-grade wimpy tumor, but there are some that become more aggressive and under the microscope, and we call that pleomorphic. And there are also people who have mixed ductal and lobular. And the staging rules are that if it's a mix, then we call it ductal. This gets into why I think it's really important that you get a biopsy when the tumor becomes metastatic, because you want to know which you're dealing with. If the tumor is more aggressive, it can lose estrogen receptor expression. It can gain HER2 expression. And tumors really can change over time. That is not common, 10 to 15% of the time, but numerous studies have shown that, and we've certainly seen that by imaging. So if you need to know what you've got so you can know if you have a target for therapy. So ER and HER2 are rather important. Just like ductal, bone is the most common site for lobular tumors, and in that sense, it's really not different than ER-positive ductal carcinoma. But the difference is this whole issue of the lining of different parts of the body can be coated with cells, and as Dr. Oesterreich alluded to, there can be these tiny little spots that 1 or 2 millimeters. That's pretty hard to find by any imaging. Sometimes an endoscopy or a cystoscopy or maybe an MRI can be helpful, but sometimes you can't find it and you can't measure it. You're kind of going with an indirect issue, which might be pain, might be blockage of something, or might be an elevated tumor marker, and then you can follow that. We have some experience with estrogen receptor imaging, and that does work in lobular tumors as long as there's a concentration of estrogen receptors. But one of the frustrating things, I think, for everybody is that you can do an endoscopy and you're looking on the inside of something and the tumor's pushing on the outside and you can't actually find it. I think the targets for breast cancer are estrogen receptor and HER2, and those are really important. And I philosophically think that you can recycle endocrine therapy. If it's worked for you in the past, it could work again. So if it's worked for you and then you end up on chemotherapy and that works for you, it's not off the table that endocrine therapy could be used again. And I've actually used the same agents in people once we've knocked down their disease with chemotherapy. I'm not saying that works every time. I'm just saying I think it's reasonable to think about. And of course, it really depends on what the tumor's up to. There are a bunch of ways you can monitor the tumor burden, and you can also think about participating in a clinical trial. One of the problems, if you don't have measurable disease, is that you might not be eligible for a trial. We have lobbied pretty hard to change that with some studies. Notably, our FES studies allow non-measurable disease, and there actually have been intergroup trials that allow non-measurable disease. And I think as industry realizes the importance of managing tumors in bone, which is a tough site to measure, they're also allowing non-measurable disease. But that's a frustration for people, and obviously that's a group of people we haven't figured out how to care for. If we don't include you in the study, then is the study relevant to you? So with that, I think we just want to take your questions. And, all the FES studies have been funded by the NCI in a program project grant. But I certainly want to also thank all the foundations that have supported our work over the years and the patients who've kindly participated in the trials, as well as, their families and my colleagues.
Okay, so once again, if you have questions, if you can write them on postcards. We'll also be taking questions from live stream that they'll run to the front. And I'll just get started. First question is grade 3 ILC considered fast growing? And I think grade 3 is unusual for ILC.
Right. Classic ILC is grade 1, low key 67 if you're measuring that. And so grade 3 would be considered a more aggressive tumor and would make me think about the pleomorphic idea. So grade 3, so there's this test that we use in the early stage disease, the Oncotype DX test. And grade 3 is going to be more likely to be Oncotype DX high, more likely an indication for chemotherapy.
Back to imaging. Is there one type of imaging that's more appropriate than other types for finding mets along in the abdomen or in other parts where, particularly where ILC spreads, it's not as typical?
Right. What's just difficult is I wish there was a good imaging test, and there's not. I mean, I think where we're really all very, very frustrated is in the abdominal cavity in the belly. And you can, sometimes the CT will really show the caking of the omentum, real obvious thickening. But boy, is that hard to get at because there's so much of other stuff going on. And so, imaging is really good at looking at the liver and the inside of the liver and the lung and the inside of the lung and the lymph nodes and their size. It's just weaker when you're trying to find other things. And so that's where you can get into either an exploratory lap or a endoscopy. I think if you're looking around the neurologic system, if you're looking around the spine or the eye or the brain, MRI is going to probably be very useful. Mm-hmm. But for the abdominal cavity, I'm not sure that that's really going to be helpful.
And a related question is maybe go a little bit more potentially into the future role of tumor marker tests. If ILC is hard to detect on scans, the potential role of tumor markers for surveillance and the and liquid biopsies.
Right. So I think tumor markers are a bit of an indirect measure. They're often really kind of an epiphenomenon, not a direct measurement. We don't have the PSA, the prostate-specific antigen. We don't have that for breast cancer, and that's unfortunate. However, we do have a few indirect tumor markers which can be useful in some patients, and it's sort of a bit of a working it out for each individual whether that's useful. But I think, as Dr. Oesterreich alluded to, we're in this era where liquid DNA may be very helpful, and what liquid DNA is just it's shedding of the tumor DNA that hangs out in the blood. Mm-hmm. And I guess I do feel more optimism about that than I do about the CTC, the circulating tumor cells, but that's another option. The problem with CTCs is everybody doesn't circulate tumor cells, so you have them or you don't. But the liquid biopsy, everybody has, and unfortunately there's a huge false positive issue there as well. But I think the liquid biopsy is probably going to be where we go, and what is potentially there is you could follow the particular signature of your tumor there. So if you're talking about the PI3 kinase pathway is important, and there's a mutation in that pathway, you could find that in the liquid, and then you could determine whether that went away. But that's all research right now. That's not ready for prime time.
So maybe I can just quickly follow up on this. So there are a couple of studies. There was a paper published last year, actually, from a group in London, where they did liquid biopsy and they did imaging, and they compared this, and they thought that maybe approximately 6 months before you can see the tumor on the imaging, they were able to detect specific mutation in floating DNA in the blood, right? So I think the idea that maybe you can pick it up in the blood in the so-called liquid biopsies is clearly out there. We need more work. But like I tried to explain earlier, I think there is a unique opportunity there in lobular cancer because in contrast to ductal, in 90% of those tumors, we should be able to figure out this one mutation which is still there throughout progression of the tumor. You have that EQT mutation in the primary, and at least a few tumors we sequenced now, the same EQT mutation is in the metastatic lesion. You know, it just carries it around with it. So in theory, you could dream, right? You could dream and think of like a finger stick and look at this specific EQT mutation in the blood and could look once a year. Again, we are far from being able to do that, but that is something you could envision where potentially you wanna head to, yeah. I agree with like the whole CTCs. I think there are lots of false positive. You find them and then maybe they never do anything, yeah. So again, it's an exciting area for research. I think lots of technologies have become very, very sensitive, so we can do a lot, but and we are working hard on it, but I think it's not quite ready for prime time.
And related a little to your answer, we had a specific question: does the loss of ecahedron occur in the gastrointestinal canal? And if so, is there a genetic connection between stomach cancer, for example, and metastatic ILC, potentially?
Talk about that.
Yeah.
Genetics. You can talk. So, I mean, I can just quickly tell that the tumors, the primary tumors, have the same genetic loss as compared to the metastatic recurrence in the GI tract, right? So that EQT is lost in the primary ILC. It could be a mutation. It could be various other means how the DNA is messed up at that locus. And that same genetic change happens in the metastatic lesion. There's something about gastric cancer and EQT changes in gastric cancer as a primary tumor, but maybe I should head this over to the physician.
Oh, I'm not a gastric cancer expert, but no, I think, the E-cadherin loss is just about the cohesiveness of the cells, and gastric cancers can be difficult to diagnose. Malt tumors can be difficult to diagnose because they just are spread diffusely, and it's hard to get a common to obtain them in biopsies. So when the tumor spreads in this linitis plastica fashion, sometimes it's actually missed, and that's obviously a tragedy. You've gone through an EGD and a biopsy and you don't have a diagnosis. But usually it's obtained, and so there are 3 different kinds of things that can do this in your GI tract, and they're treated completely differently. So you need a tissue diagnosis for that.
Okay.
Maybe actually one thing I can just quickly mention on these liquid biopsy, one thing our group has done and many other groups as well is look for genetic changes in estrogen receptor. So it turns out that the target of endocrine therapy, which is the estrogen receptor, is mutated in approximately 30% of patients with metastatic disease. And again, we, and as well as others, have found that mutation in liquid biopsies. So you can take blood, you can isolate DNA, and you can specifically look for these estrogen receptor mutations. And the presence of those mutations is significantly associated with lack of response to endocrine therapy. So that is, I think, maybe at the moment the best example for using liquid biopsy and taking a genetic test and know that now that target for that therapy, doesn't work any longer.
Thank you. Lots of questions on endocrine treatments, and first, is there a particular AI aromatase inhibitor that is more effective on ILC?
Yeah, I think all the endocrine treatments are, in general, very effective in ILC, but just because your tumor expresses ER doesn't mean it's functional. So some patients with lobular cancer also, benefit from chemotherapy, but I am not aware that the 3 huge studies of aromatase inhibitors looked at the lobular subset and characterized whether there was one better than the other. That's sort of what the trial that we're doing is to look at, is to see, there is a question of whether or not, in general, estrogen depleting therapy is superior to blocking therapy in lobular tumors. That's the question that we're trying to ask with this trial that we're doing. But I think they all work, and I think what I think is that the AI that is best for you is the one you tolerate the best. because you end up on it for a long time, and you're not going to want to put up with crummy side effects.
Yeah, so like Dr. Linden said, I think there's no study out comparing the different EIs. And going back to some of those studies and reanalyzing retrospectively for ILC is difficult because the number is just so small, right? You only have 10% of patients in this trial at best who have ILC. So it will be tough to get to understand the significance of these findings. I do have to say there's one study which was presented by Dr. Metzger at San Antonio and was also published subsequently, where they didn't look at different eyes, but they compared an AI with tamoxifen. It's in a very big clinical trial. It's called Big 198. So in this trial, they found that the response to tamoxifen is significantly worse as compared to AI. And that difference was larger in patients with ILC as compared to IDC. However, that's one study, right? And at the moment, there is an effort of a number of groups who came together and said, okay, we'll take each endocrine trial, what's out there. There's the ATAC trial, TEAM trial, many other trials, and retrospectively look in those samples, which one is IDC, which one is ILC, and how does the response to endocrine therapy compare in those two histological subtypes. That data isn't out yet, but I'm sure it's going to be there in like 6 months or so. So that will be informative to see, does it confirm the results from the Big 198 study or not? We can never base anything on results from one study. Yeah?
Thank you. Related to the endocrine therapy, and probably related to this clinical trial that you're both working on, what's the recommended treatment for premenopausal women with ILC? And based on some of the evidence out there that tamoxifen might not be as effective as AIs for ILC.
Yeah, this is tough, and this gets into the soft and text trials and the data that we have. And if you have a big enough problem that requires chemotherapy, there's a really good chance that ovarian suppression is going to help you out in terms of allowing you to take an aromatase inhibitor and allowing us to basically give you more aggressive endocrine therapy. That being said, ovarian suppression is really pretty hard on people, and some people really don't tolerate it well. So I try to let people try it on with the shots before we take the ovaries out, because I don't want to give them hormone replacement. And some people, we try it on for a couple years, and then they go back to being premenopausal. And if you're premenopausal, the only option is tamoxifen or drugs in that class, like teremethine as well. But those selective estrogen receptor modulating drugs are really the only thing that works if your ovaries on. But I think if you have a larger tumor or a more aggressive tumor, there is a role for considering turning off your ovaries and taking an aromatase inhibitor. So I was just lobbying the Pittsburgh group here to include premenopausal women in their study, but that involves turning off your ovaries, and that is hard on people. And menopause is not something most people enjoy, and so when we do it and we really aggressively turn it off, it can be uncomfortable.
Yeah, maybe as a follow-up. So Dr. Linden talked about this clinical trial. I mentioned this earlier. The PI of this clinical trial in Pittsburgh is Dr. Jankowitz. And we looked at this trial recently, and accrual has been good, but slower than we wished it would be. There are fewer patients on trial than we had expected at this point in time. And she keeps really good record. Why do patients not go on the trial? And when we looked at this recently, sat down as a group, it turned out that there were many, many more premenopausal women with ILC than we had expected. And it is still relatively early. It could be a pure statistical fluke, or maybe the data on ratio of pre- and postmenopausal women maybe has changed over time. Right. We base it on old data. Maybe now there are more premenopausal women. It is clearly something I think we pay attention to, and it would be good to include all the sites and look at that. Yeah, that's an
right, but it's an interesting. Ask. It's a big ask. I mean, if when it's out, you're going to have a centimeter of tumor and no nodes, I don't know that you're going to want to bother going through ovarian suppression at 35. So these are tough questions.
Okay. One question that we hear a lot in any of the social media groups and online, and it's a I think it's a perception, and it's a change too in how much we've come, I think, in understanding ILC as a different disease. But the standard of care and the clinical treatments are identical between ILC and IDC. So what are your thoughts on an evolution of treatments for ILC different from IDC based on what we're learning?
I just think it's all evolving, and we're really trying hard to make sure we give the right treatment to the right patient. But ILC is a different pattern of spread. It has its idiosyncrasies, but at the end of the day, it has an estrogen receptor, progesterone receptor, and HER2, and those are really important targets, so you should be treated the same way. And that's why I think we can mine some of these studies where we had, if we had 1,000 women with breast cancer treated, we could look at the 100 or 200 who were ILC and try to see what happened to those patients, because I'm hoping that we will ultimately develop better targeted therapies and get at that stromal interface between the cells that are sort of running out in a single file and whatever's happening, the dialogue they're having with the tissue underneath. But right now, that is our best recommendation, and actually that is, NCCN guidelines standard of care is to give you the exact same things. And, so there are lobular cancers that have benefited from all the traditional therapies that we use in ductal cancers, and I wouldn't want to deny somebody access to those. So even though the patient might have an ER/PR positive tumor, if it kind of laughs at endocrine therapy and you don't get any headway with that, then you need all the good chemotherapies that we have.
Right.
I mean, that's why we research it really hard, right? That the goal is to have this, what we call personalized medicine, yeah? That's why we try to understand this. What's different? At the moment, we haven't identified a pathway where we have a current drug that we can say, okay, this is what we should give, this is so different. But the research really only started a few years ago, right? So I think, hopefully, moving forward, we will have pathways which we have identified, which are enriched in ILC, where we have good therapy for. That's why we study it.
Following up more on the research, if the microenvironment is more important in ILC, does that mean that lifestyle and complementary therapies might be even more important, i.e. to change the terrain?
So just to clarify, when I talk about the microenvironment, I talk about the environment of the cells, right? So, and we understand very little about this. I mentioned earlier that there's actually a really good group here in Seattle, headed by Chris Lee, who is studying various epidemiological aspects of disease development, of risk for disease, and then progression. So he has shown that the effect of, for example, hormone replacement therapy is more significant in patients with ILC than IDC. I think he's looking at various other factors like, alcohol and things as well. But
I think fat cells, because unfortunately they're a source of estrogen, and so I think that would be a question is whether weight loss and exercise are going to be helpful to you. Yeah. But what I sort of joke with my patients about is we didn't fix your breast cancer to have you die of a heart attack or stroke. So we know that those lifestyle modifications are going to be good for you overall. Are they going to help a patient with ILC more than a patient with IDC? Maybe.
Okay.
But we don't know that. Well, all we know is the data that Chris and others gleaned from the Women's Health Initiative, which is that taking the estrogens and really probably much more importantly the progestins is a feeder for ILC. And so those ads that I believe are in the sports pages as well about the Fountain of Youth, where you can take that vitamin and really it's a hormone. Those are bad for you. For ER positive tumors, and it includes lobular tumors, those are a bad idea.
Okay. A couple of questions about how to better get information about your tumor and your diagnosis to begin with. A path report with the diagnosis of METS didn't tell someone if they were luminal, pleomorphic, et cetera. How do you get that information? And how can a patient find out if her ILC mets are in the 1/3 with a high immune signature?
Right. So it's not standard of care to give the immune signature out, although I think we're starting to comment on it, you know, whether you have a TIL, an infiltrating focus of lymphocytes. The weird thing about TILs is there's a polarity to them, so the sample that you have might not contain the TIL, and there might be a TIL there. I think that's going to start becoming more of a standard of care. But the truth of it is primary tumors are much more standardized than metastatic tumors. And so the path report might say, oh, this sort of looks like the other tumor, it's breast cancer. And it might really not say much more than that. I'm always disappointed by that, and I ask them to do a side-by-side comparison and say, have you got the original tissue block? Does this look the same? And then I ask for one other thing, which is that we repeat the IHCs, the standard package that we do in the primary, that we do the estrogen, progesterone receptor, and HER2. So you can ask for that. You can ask for both those things. You can ask that the path be compared with your primary. You can ask if it looks like lobular, and you can ask for I think, a repeat IHC, because the question is not what you had then, but what do you have now, and how should we treat you?
A question related: if a patient was diagnosed many years ago, is the tumor still usable?
Yeah, it depends on, I guess, the lab conditions, but usually it is. This is a weird thing. I mean, they have an incinerator in pathology and they use it, but there's a little tiny block that gets saved. There's a tissue block, and usually most labs save that for a very long time. So often you can go back and query that.
Okay.
Yeah, I just very quickly, I mean, there have now been such great development in technologies. We actually just published a study like a few months ago where we use even bone metastasis from like more than 10 years ago, where it was always, wow, you can't touch them, they're decalcified, to be able to make sections through the hard bone and stuff. And there are now such great technologies that you can use really aged tissue which have been laying there, which went through very harsh fixation and decalcification, and you can do all kind of molecular studies and staining. And so things have changed as compared to even like just like 2 or 3 or 4 years ago. So yes, I think old tissue is of very high value.
Okay. We're going to jump back. This is more around surgery, questions with surgery. And one is, I had a de novo diagnosis. Is there newer research about whether to remove the original tumor surgically or not is valuable?
Yeah, so in kidney cancer, there's data that that's helpful. In breast cancer, there is no data that it's helpful, and we had an intergroup trial randomizing people to either having that tumor removed or not removed, and we had a really difficult time accruing to that trial because most people have very strong beliefs that most people think it doesn't help at all. Some people think it does and they just want it out, and it's not wrong to take it out. In general, we don't remove it unless there's been a problem. If you have a wound that won't close, you know, that's really a local problem for you, we'll use some treatments to get it under control and then remove it to improve your quality of life. But there is no data that suggests that that primary tumor is the driver of the problem that you're really going to be symptomatic from, which is the metastases. And so that's why I keep talking about, I want to know what the metastases are doing. The metastases are what the problem is. So I have many patients who presented with denovo, and that's actually very common with lobular because you don't even know you have it. And we don't touch it because those tumors are not problematic to people, and that's not what is their problem. Their problem is the metastases in the bone, the metastases in the ovary, or wherever it is. So no, I don't recommend removing it, but unfortunately we're never going to really know because we couldn't effectively enroll to that study.
Another surgical related question, and this I think is really more of a first diagnosis, about neoadjuvant chemotherapy before surgery or a mastectomy, and what thoughts are on that for
so
ILC?
we're really excited about this clinical trial that we're doing with the different endocrine therapies. There are also clinical trials. There's one currently enrolling for CK4/6 inhibitors in lobular tumors specifically. I think those are really promising, and I could get excited about that. Neoadjuvant therapy for estrogen receptor positive disease is less likely to be effective than for all the other types of breast cancer. So the triple negatives and the HER2 positives get a really satisfying, nice shrinkage of the tumor with neoadjuvant therapy. It isn't a chemotherapy. That doesn't mean that the chemo didn't work, but it is going to be less effective at downstaging you and offering you a lumpectomy when a mastectomy was what was indicated. So if you have a locally advanced tumor that's going to be a little bit difficult, there's nothing wrong with giving the chemotherapy up front. In fact, that's standard of care. But I'm always sort of caution people not to be concerned that that isn't going to make it so that you had a big thing go become a small thing. Because what's more likely, and this gets back to the whole net-like structure, is you're going to decrease the cellularity of the tumor, but it's still going to take up too much space. So you're still going to need just as big a surgery. So when we're giving a neoadjuvant chemotherapy to somebody, that's because they have an advanced tumor and they're going to need the chemo anyway. And the surgeon and the radiation oncologist would like us to tighten it up a little bit before it comes out. And if you're looking for, clues that the chemo worked, the pathologist can give you a bunch of hints. They can say, look, there are these open spaces, the cellularity is less, or the proliferative index is less. And then that sort of means it's been effective, but it unfortunately doesn't downstage effectively.
Okay. A couple of questions about specific sites, metastatic sites. With bone mets, does a tumor grow around the outside of the bone?
Oh, great question, and no, it goes in. And it can be in the marrow or in the bone. Okay. So even though you have a lining around your bone, it's in the bone, unfortunately. Bone is different. I mean, bone is a mesh, really. It's a trabecular mesh of scaffolding, and so that's how it...
Even if it generates from any type of carbohydrate. So this is back to more diet and environment control.
Healthy diet is a good idea. Yeah. Added, what I think the food industry has really snuck in a lot of additives, and none of them are really very good for you. The extra sugar or the corn syrup or the aspartame or the other, the sort of synthetic sugar. I mean, none of that is healthy. But the sugar that you find in a piece of fruit, I think, is pretty hard to argue about the health of that. And the carb thing, Americans have a huge obesity problem, and there are a bunch of ways to solve that. I think for some people, going on a low-fat diet works really well. For other people, going on a low-carb diet works really well. And, you want it to be a functional thing. You want it to be a lifestyle change that you're going to not be struggling with. So you don't want to go up and down in your weight. You want to just make a lifestyle change and have a little more lean body mass and a little less fat. But it's kind of a personal thing, what works for you. I think one of the ways that the food industry has tricked us, though, is, you can't only eat just one of the potato chips. I mean, they're a little bit addictive. So I think with a bunch of the added sugars, they just make you want more because they're not really satisfying. So I don't think they're good for you, but I don't think that, the reason that you have cancer is not because of eating a corn dog. I mean, I just can't go there. I don't think it's healthy food, but I don't think that's why you got it. And I don't think that eliminating sugar is going to solve the problem. It's just about really eating, healthy, as Michael Pollan would say, real food.
Well, thank goodness corn dogs are on the table. That's good. Thank you. Okay. Let's move a little bit into clinical trials. And Dr. Linden, you touched on RESIST, on non-measurable disease. But I think a lot of people may not know what that is. And so can we go back a little bit and talk about what RESIST measurable is and how that applies to ILC?
Yeah. So it's a problem in that, most clinical trials were done by looking at sort of the radiologist having something they can measure in 2 or 3 dimensions in your lung or your liver as a really easy way for them to follow tumor response. So RESIST is a tool that we use to measure disease, and it's easier if you just can, put the calipers around it and say it's a round ball, and of course lobular tumors just don't do that. So I think as we look back at most of the clinical trials that define the utility of chemotherapy, they were using RESIST evaluable disease. But truthfully, for people with ductal cancer as well, there's this bone problem where bone is not really RECIST measurable. So the people with bone metastases and the lobulars were excluded from many trials because they didn't have RECIST measurable disease. They couldn't meet that criteria of having something that the radiologist could put calipers around in 2 dimensions and calculate the volume and calculate the amount of shrinkage or the amount of growth. And by the way, the other trick with RECIST is if, it doesn't really matter what the one spot is doing. If you have new spots that appear, then you have progression. So more modern trials have included these patients by coming up with different ways of measuring disease beyond RECIST. And RECIST 2.1 is a little different and does allow non-measurable disease. And so the trials that got us the CK4/6 inhibitors allowed non-measurable disease. So I think we're making progress, and most trials are now allowing it. But the reason it's there is because we want some very clear, ooh, this is better, this is worse judgment. And that can be difficult. That can just be difficult in the sort of day-to-day management of patients with lobular tumors.
So.
We have time for one more question, and thanks for everybody for all these really great questions. I want to finish it off by saying we've learned a lot about, we know a lot more about lobular than we used to, and moving forward with research, both at the molecular level to understand the disease and at the clinical level to understand and apply treatments. What is it that you would tell patients that they, that they can do to be meaningful contributors to this, and where do you see this moving in the future, specifically for metastatic?
I would say they should all contact you and join the Lobular Breast Cancer Advocacy Group. Hopefully everybody got the card. If not, go and find Lee and get the card and get on the website. And I think that will be a good start.
Okay.
And I think, get the word out. I think raise awareness of the disease, no matter if it's, with your family or with your friends or your physician or researchers, wherever you are. I think that will be a great start.
Yeah, I think we are changing, and I think we're doing more and more trials developed just to really target different populations, and we're going to need a major network of advocates, because if it's all these rare diseases, you're going to have to travel to get the right thing. That's the tough part.
Right.
So we are working to develop some better tools for measuring things. We're going to put another trial through ECOG Akron to look at measuring response in bone, and we're going to test a tool that has been hypothesized by other centers called PERSIST. That is a PET plus RECIST. We're going to test that and a few other ideas, because in bone there are lytic metastases and sclerotic metastases, and we think that PET may be particularly effective for the lytic metastases. So we're going to test that. We are testing estrogen receptor imaging, which I think will be a helpful tool to identify the presence of tumors that can concentrate estrogen. So I think, the tips I had for looking forward are that consider a rebiopsy and looking for ER and PR. Consider whether there is a trial available, and often the trials, it's much more likely that a breast cancer trial is going to include a lobular patient than it is going to include a male patient. I actually think that everybody should be included in most of these trials, and that's how we're going to get better information for people. And so I think the question is there a trial out there that could work for you that seems appropriate?
Okay. I will say that on our brand new landing page, lobularbreastcancer.org, we have posted links to breastcancertrials.org, which is a very accessible, searchable site for clinical trials for breast cancer, including one for metastatic breast cancer, and to the Metastatic Breast Cancer Project, where everyone with lobular metastatic disease should contact them and send information in, so we start building a meaningful tumor bank to be able to do research and actually have the material to study for in the lab, so we can understand the disease later better. I also wanted to say that we're very hopeful and we plan to have recordings. I know people have been maybe scribbling notes or something. We plan to have this recorded and hopefully will be available in the future, and we will try to put the information out about where those recordings of these sessions can be available in the future for future reference. And I just want to thank you all so much for a wonderful presentation, and thank you so much for being out here.
Thank you.
So one other thing I will add is the reason why we're even here today and having this conference is because of Joyce, who got in and said we really need to have sessions on lobular and we need to have sessions on metastatic lobular, and it raises the profile of this disease, which actually really rarely makes it on agendas of conferences and meetings. Sometimes it's not on websites. This is something that all of us who have invasive lobular breast cancer can do, is we can go ask, oh, you're having a meeting, can we have a presentation on lobular? You know, you're having a conference, can we have some research presented on lobular? And we start asking and raising that, and we do that broadly. We're going to draw more attention to a disease that doesn't currently get a lot the attention that it deserves. And so that's something that we can all specifically do to help shine a light and elevate lobular breast cancer and move more quickly towards some better, some other solutions for the disease. And then just to wrap up, and then for our online audience, the conference is going to resume next door and at 2 o'clock. And for online, you're going to want to go back to the main conference webpage and then click the link to be able to tune in to the afternoon sessions. So thank you.
I don't fear him like you do. As the world revolves, the sun, I hope the light that I've become can sleep for once. I won't leave it like you do. I won't leave it like you do. I won't leave it like they do. I don't need him like they do. Just wanna sleep.